Hello everyone, this is Dr. Richa. In this video, we will talk about the drugs which can be used in heart failure. So here is a flow chart showing that what happens in heart failure. In heart failure, there is decrease in the cardiac output. Heart is not able to pump adequate amount of blood. And since cardiac output is the determinant of blood pressure, there is fall in blood pressure. Now, whenever there is fall in blood pressure, body initiates the responses so as to correct the blood pressure. And these are activation of the sympathetic nervous system by means of the baroreflex. So there is increase in the sympathetic activity, and also because of decrease in the blood pressure, there is decrease in the renal blood flow. This causes activation of the renin-angiotensin system. So there is release of renin, which causes formation of angiotensin 1 from angiotensinogen, and in pulmonary capillaries, this angiotensin 1 is converted to angiotensin 2. This angiotensin 2 has lot of actions. One is arterial constriction throughout the body. Then this arterial constriction basically increases the peripheral resistance. So whenever peripheral resistance increases, peripheral resistance is also a determinant of blood pressure. So blood pressure is going to increase. Then there is release of aldosterone from the adrenal gland, which causes sodium reabsorption. Also, there is direct effect of angiotensin 2 for sodium reabsorption. Whenever there is increase in sodium reabsorption, there is also increase in water reabsorption. Then it also leads to thirst. There is sensation of thirst, so that the person drinks more water, and there is ADH release, which causes more reabsorption of water from the kidneys. So both of these will cause increase in body water. Here also, with the sodium, water is being reabsorbed, so there also will be increase in the body water. All this are going to increase the blood volume. Okay. Now, increase in sympathetic activity leads to arterial constriction. Okay, so that also increases the peripheral resistance. Also, it leads to vein constriction. So, vein constriction leads to increase in the preload. So, veins are going to constrict and blood is going to go towards the heart, and that is going to increase the preload. Increased blood volume also is going to increase the preload. So, there will be more blood returning to the heart, and this will cause increase in the cardiac output by Frank-Starling's law. Okay, so whenever the end diastolic volume increases, whenever the preload increases, there is a stretching of the walls of the heart, and this causes increase in the strength of the contraction, that is increase in the cardiac output. So fundamentally, these are the compensatory mechanisms which tend to increase the cardiac output and hence tend to correct the blood pressure. However, these compensatory mechanisms act till a certain limit, and afterwards these compensatory mechanisms themselves become damaging. Okay, so what are these that damage? How it causes? First, afterload, if it increases too much, that means the heart has to pump against a very strong load. What is afterload after all? See, if this is the heart and the heart is pumping blood, afterload is the pressure which has to overcome in the aorta. So if this peripheral resistance is increased too much and the BP also increases, basically peripheral resistance we are talking because of the vasoconstriction, if it increases, then this ventricle has to contract against so much resistance which is present in the vessels. So that means the work of the heart is increasing, but the heart is already failing, isn't it? Second, because of this too much increase in the preload, in Frank-Starling's law, what happens that it acts only within physiological limits, right? So if it is too much stretching the wall of the ventricles, the fibers of the ventricles, then the cardiac output is not going to increase. In fact, it is going to decrease. Okay, so that we should remember that too much stretching of the length of the muscle fiber, that also is not good. Okay. So that leads to increased wall stress. So both excessive afterload and excessive preload are bad. Then next, this heart remodeling is one very important aspect, that because of this excessive sympathetic activity, excessive angiotensin 2 formation, and also because of the release of aldosterone, heart starts to remodel, but not in a very good way. So there are proliferative changes in the heart. That means the muscle fibers, they start proliferating. Anti-apoptotic changes, again they are proliferating and not dying. And there is deposition of the collagen also. So there is fibrosis. So not only the muscle proliferates, but in between the muscle there is deposition of the collagen, which is not good for contraction. Okay, because this collagen is not going to contract, only the muscle fiber contracts. So that is known as fibrosis. So these heart remodeling changes are not good for the long term. However, for short term, body is initiating all this as compensatory mechanisms. So for the treatment of the cardiac output, we can target at multiple levels. What are these multiple levels and when they are used, that we are going to talk. Okay, so first is very important. First drug is ACE inhibitor. Okay, so here we have to block. Okay, so we use ACE inhibitors. If we use ACE inhibitors, you can tell what will be the actions that it will lead to prevent the deterioration of this heart failure. Angiotensin 2 will form less. There will be decrease in the afterload because vasoconstriction will be lesser. Then blood volume that has increased too much. If it increases too much, that will also lead to edema because the hydrostatic pressure in the blood vessels is going to increase, and that is going to flow out of the blood vessels. So this blood volume is also going to decrease. There will be decrease in the preload. So at both these levels, at the afterload and preload level, these ACE inhibitors are acting. Okay. Plus, you see, angiotensin 2 is the main mechanism for heart remodeling. So when angiotensin 2 is decreased, this heart remodeling is decreased. Okay. So it goes towards the beneficial aspects. So ACE inhibitors, remember, these are the first line drugs. In fact, the indications for uses of this ACE inhibitors are all CHF until contraindicated. Okay, so this is the first line drug given in all forms of CHF until contraindicated, or there are excessive side effects. So what are these? For example, say suppose side effects of cough and angioedema, because these are the side effects, the ACE inhibitors will be discontinued. So in that case, instead of ACE inhibitors, we can give which drugs? We can give angiotensin receptor blockers. So this details about this I have already dealt in the video on RAS inhibitor, so that also you can watch. So if cough and angioedema is there, then angiotensin receptor blockers can be given so that they prevent the action of angiotensin 2. That is one thing. Second, suppose there is some contraindications for use of this. For example, renal artery stenosis. In renal artery stenosis, ACE inhibitors and ARBs are not given. So in that case, which drug to use? Yes, there is another combination of drug which we are going to talk very shortly. Hydrolazine plus isosorbide nitrate. Hydrolazine plus isosorbide nitrate orally. The combination of that can be given, and like ACE inhibitors, it has also been shown to reduce mortality. Yes, there are certain drugs which are used for symptomatic management. They do not prevent the progression of the disease. But this ACE inhibitors and also this combination of hydrolazine and isosorbide nitrate, they decrease the mortality. Okay, so we'll talk about this little bit shortly. Right, so that was about ACE inhibitors. They are used in all CHF, only not used if there are a lot of side effects, then we go with ARBs. If they are contraindicated, we go with the combination of hydrolazine plus isosorbide nitrate. So that is first. Second drug which we can use is this, block the sympathetic activity, and we use here beta blockers. Beta blockers. Okay, now pay attention here because it is little bit difficult to understand why we are using beta blockers. See, sympathetic activity, what it does is it also increases the heart activity. So there will be increase in the heart rate and there will be increase in the stroke volume. So it maintains the cardiac output. So that is good during heart failure, isn't it? So when you are blocking the beta activity, because in heart we have beta 1 receptors, this will also be blocked. Right. So there is decrease in the cardiac output when we give beta blockers. For some time there will be decrease in the cardiac output, but over time when you continue beta blockers, this is going to recover. Right. So that you should remember, the dose starting should be careful so that this fall in the cardiac output does not become harmful. But this beta blocker is used here because this interferes with this heart remodeling. So the long-term effects of increased sympathetic activity which are damaging to the heart because of heart remodeling, that are prevented. Okay, it is so, remember that it is not acting here in afterload or preload, because actually sympathetic activity acts on the vessels by means of the alpha receptors. So this and all is not going to be blocked. In fact, the effect on the heart, it is direct effect, if you see, that is decreased inotropy it is occurring. But the main reason for use of beta blockers is decrease in this heart remodeling, right? So that is one thing. And this beta blocker is again a drug which is combined with the ACE inhibitors in case of mild to moderate CHF. Okay, understanding? And this beta blockers also reduce the mortality. They affect the disease progression because they are interfering with this heart remodeling. So that is the second type of drug. Third drug is aldosterone antagonist. Yes, aldosterone antagonist. So again, we are talking about drugs which are interfering with heart remodeling, because these are the drugs which interfere with the disease progression. Please remember, okay? So aldosterone antagonist we give. Okay, and aldosterone is another agent which is causing this heart remodeling, and this aldosterone antagonist is given in moderate to severe CHF. Understanding? So mild to moderate CHF, we are combining ACE inhibitors with beta blockers. Moderate to severe CHF, now we are combining ACE inhibitors with the beta blockers with aldosterone antagonist. But one thing you remember here, that this aldosterone antagonist, yes, it is having some effect with sodium reabsorption. If you give aldosterone antagonist, sodium reabsorption is going to decrease. There will be decrease in the blood volume. So there will be effect on this preload as well. But the action of aldosterone, if you remember physiology, is what? It causes sodium reabsorption and potassium secretion. Okay, so potassium is being lost from the body. Now you have already used ACE inhibitors which are decreasing the release of aldosterone, because angiotensin 2 will form less, aldosterone will form less. Now whatever aldosterone is there, that also you have blocked. So potassium secretion also is not happening. So when these two drugs are combined, that means the ACE inhibitors and aldosterone antagonists, we may see hyperkalemia. So we have to monitor for potassium levels in the body. We have to be careful with the dose as well, right? So these are the three main drugs which are disease modifying drugs, and they decrease the mortality because they interfere with the heart remodeling. And I told you that when ACE inhibitors are contraindicated, we give hydralazine plus isosorbate nitrate, and that also is disease modifying. That has been found that it decreases the mortality. Now, when beta blockers are contraindicated, there is another new drug which has been introduced which can be used, that is ivabradine. Okay, so that can be used instead of the beta blockers if beta blockers are contraindicated. So these beta blockers are actually bradycardia producing anti-anginal drugs. Okay, so they maintain the coronary circulation and they are producing bradycardia. That is also again helpful in heart failure. Why? Because the heart rate increases the oxygen consumption. Okay, so we don't want too much increase. In fact, beta blockers also are interfering with the increase in the heart rate, right? So that ivabradine can be used, right? So we have seen ACE inhibitors, beta blockers, and then aldosterone antagonists. Now moving on to other drug, that is we can use diuretics. Okay, diuretics. So what will these diuretics do? Diuretics cause loss of the fluid volume from the body, that is the diuretics. Okay. Now, this diuretics, when they decrease the fluid volume, where are they acting? They are basically decreasing the preload. Okay, so the volume which is returning to the heart is decreasing, and these diuretics are recommended, especially the loop diuretics. Okay, furosemide, loop diuretics are recommended. When are they recommended? If there is heart failure plus congestive symptoms. Congestive symptoms. What is this congestive symptoms? See, when heart is failing, left heart suppose is failing, so there is interference with the forward flow. It is not able to pump forward, cardiac output is not going forward, so there is development of the back pressure. Everything is jamming behind. So behind the left atrium is what? The pulmonary circulation. So there will be accumulation of more fluid in the pulmonary circulation, and when that happens, there is leakage of fluid from the pulmonary circulation and there is development of pulmonary edema. Okay, so what is that? That is pulmonary congestion. The person will start having dyspnea, also breathing problems, that is. Okay, so in that case we give this diuretics. So normally, in case if the person is not symptomatic, then these diuretics are not recommended. Please remember. Okay, not recommended if the person is not symptomatic. Only in presence of congestive failure, congestive symptoms in heart failure or acute heart failure. Because acute heart failure means again it will fail suddenly and there will be development of pulmonary congestive symptoms. Okay, even behind, suppose right heart failure is there and there is back pressure developing in the systemic circulation, there will be development of the edema, hepatomegaly. Then also to relieve these symptoms, diuretics are given. Okay, so that is diuretics. Chronic diuretic therapy is recommended only if diuretics are stopped and again the congestive symptoms are developing. Okay, so the person is not able to manage, the compensatory mechanisms are not able to manage without the diuretics. So in that case, chronic diuretics therapy is recommended. Okay, now sometimes when we give diuretics, there can be development of refractoryness. The person can become refractory to treatment. Okay, so when does this happen? When the person becomes refractory? One, if the cardiac output is too much less. So what will happen? That if cardiac output is less, renal blood flow will be less. The drug is not going to reach to the kidneys. It will not be able to act. So that is why the diuretics are not, the person is not responding to diuretics. Okay, so in that case, with diuretics, we add IV sympathomimetic, that is dopamine or dobutamine. Understanding? Dobutamine. Right? So that is going to increase the cardiac output and that is going to promote the action of this loop diuretic. Second, we can increase the dose. If the person had been responding before but now they have stopped responding, so in that case we can increase the dose. And third, we can add a thiazide diuretic. So that also helps with this response. Okay, so that is the other drug, that is the diuretics. Okay, now what is the other drugs we can act? We can give here, we can give the inotropic drugs. Inotropic drugs. Okay, what are these inotropic drugs? We have digoxin, okay, that can be given orally, and then we have parenteral drugs that are given IV. So we have dopamine, dobutamine, okay, dobutamine. Then we have phosphodiesterase 3 inhibitors, right? Then we have another drug that is levosimendan. Okay, so that is inotropic drugs. First we'll talk about digoxin. These parenteral and other drugs we'll talk later. Okay, so coming to digoxin. Digoxin, the mechanism of action I have already dealt in another video, so I am not going to go talk about that. Okay, so digoxin increases the cardiac output, it increases the contractility without much increasing the oxygen consumption. And digoxin is recommended in 2 cases of heart failure. What is the use of digoxin? One, heart failure with presence of atrial fibrillation for controlling the ventricular rate. Okay, so that is one, because digoxin increases the cardiac output, increases the contractility, it also decreases the conductivity so that the atrial impulses don't pass through the ventricles. Okay, so that is one thing. Second, it is given in mild to moderate heart failure. mild to moderate heart failure, which is not responding to this ACE inhibitors plus beta blocker therapy, right? So that is digoxin. Next we can give vasodilators. So this here we can affect the vasodilators. Okay, vasodilators. I think now we are clear of all this thing. So I'll just clean the board so that we have some space to explain. Okay, so vasodilators, if we give, what is going to happen? Vasodilators is basically, it is going to dilate the vessels at, as its name suggests, but which vessels is it going to dilate? Okay, so we have vasodilators, and vasodilators can either dilate the veins, they can dilate the arterioles, and they can also dilate both, okay, veins plus arterioles. The vasodilators which act for veins is glyceryl trinitrate or isosorbate nitrate, glyceryl trinitrate, basically nitrates. Arterioles we have hydralazine, and the one which acts on veins as well as arterioles is sodium nitroprusside. Sodium nitroprusside. Okay. Now, these two can be used orally also, and this sodium nitroprusside is used IV, right? So this I have told you, glyceryl trinitrate plus hydralazine combination can be given in patients in whom ACE inhibitors is contraindicated. This nitrates dilate the veins, so they act by decreasing the preload. Hydralazine dilates the arteriole, so it acts by decreasing the afterload. Right? Fine. Now, this isosorbate trinitrate can also be given IV in case of acute heart failure when there is MI. So in that case, IV nitrates can be given. Hydralazine IV is used only during urgent use in pregnancy, because in pregnancy other vasodilators are contraindicated, and this sodium nitroprusside is given only IV. Okay, here both are available orally as well, right? Now we have been talking about a lot of IV drugs. What are these intravenous drugs which have been used? We have talked about. One is that sympathomimetics, that will cause increase in the contractility. Okay, so what are these? These are dopamine, dobutamine. Then we talk about PDE3 inhibitors. These are enamrenone, okay, and milrinone. Then we have another drug, that is levosimendan, okay, and then I talked about this sodium nitroprusside. Okay, so these are all IV drugs. Now, in heart failure, either it can be like a chronic heart failure, or there can be acute precipitation of the heart failure. Okay, so when there is decompensated changes in the heart failure, that means the compensatory changes which are going on in the body, now they are not sufficient to maintain the cardiac output and congestive symptoms develop. In that case, we give these IV drugs. Okay, so these are short-term drugs which are used in case of decompensated heart failure. Another drug which is used in decompensated heart failure we have seen, that is diuretics. Okay, and in decompensated heart failure we don't use beta blockers. So beta blockers is used along with ACE inhibitors for heart failure, but without the decompensated changes. So in acute heart failure we don't use beta blockers. Remember why? Because that is going to decrease the contractility, that will be harmful, right? So remember, in decompensated heart failure we use diuretics, IV, sympathomimetics, any one of these. Then phosphodiesterase 3 inhibitors, that is enamrenone or milrinone. Enamrenone is not used now because of its side effects, that is thrombocytopenia. Okay, or levosimendan. Now, how do these drugs act? How do these drugs act? See, dopamine and dobutamine are sympathomimetics. They stimulate the beta receptors. Okay. Actually, dopamine acts based on its dose. Okay. So you can remember is that it as not dopamine. I remember it as dopamine. Because at low dose it stimulates the dopamine receptors, at intermediate low dose it stimulates the beta receptors, and at higher dose it stimulates the alpha receptors. Okay, so DBA. Dopamine, remember as dopamine, first stimulated dopamine receptor, then stimulated beta receptor, and then stimulated alpha receptors. Okay, how these act? PDE3 inhibitors. PDE3 inhibitors basically prevent the degradation of cyclic AMP. Okay. Actually, how sympathetic activity acts, that it increases the stimulation of the beta receptors in the heart, which causes increase in the CAMP, and this increases the heart contractility. PDE3 inhibitors prevent the degradation of this CAMP so that there is more accumulation of CAMP. So when CAMP accumulates, there is more heart contractility. Also, not only in heart, this increased CMP occurs in blood vessels as well. Okay, and there it causes vasodilation both in arterioles and veins. So you see, it has multiple effects. It is increasing the contractility of the heart. It is increasing the vasodilation. So it is decreasing the preload also and decreasing the afterload also. And that is why this is known as inodilator. Inodilator. That means the drug which is increasing the inotropy and also decreasing the afterload and preload by dilating the blood vessels. Then this drug, levosimendan, how it acts? This basically increases the sensitivity of troponin C to calcium. Troponin C sensitivity to calcium. That means with the same amount of calcium, now more troponin C will move out. There will be more actin-myosin interaction. So tropomyosin moves out with troponin C binding to calcium, and there is more actin-myosin interaction, thus increasing the contractility. Also, this also causes blood vessel dilation. It acts by opening the ATP sensitive potassium channels. When potassium channels open, there is more moving out of the potassium, so that there is hyperpolarization and there is dilation of the blood vessels. Okay, so this also is an inodilator. So PDE3 inhibitors and levosimendan, these are inodilators, multiple effects, but remember they are used only for short-term IV therapy, right? So those were the drugs. Only one kind of drugs are remaining, that is the drugs which stimulate the BNP activity. What is BNP? BNP is brain natriuretic peptide. Okay, so we have analogs which stimulate this activity. One is neziretide. Okay, neziretide is a BNP analog, and the other is which prevent the degradation. So these are known as neprilysin inhibitors. Okay, neprilysin inhibitors. So what is this BNP? Brain natriuretic peptide, as the name suggests, natriuretic. That means it will cause natriuresis, right? Whenever sodium loss is there, there will be water loss along with that. So that happens. It also causes vasodilation. Okay, so there is decrease in the preload and afterload both. Natriuresis, anyways, it is decreasing the blood volume. So that is also this vasodilation. Now this BNP analog and neprilysin inhibitor are given in refractory CHF, the one which is not responding to other treatment. Fine. So those were the various drugs in heart failure. Let us summarize quickly that what drug has to be used in which condition, right? Quickly we will summarize. So one is like the chronic heart failure, which drug we have to use. Chronic heart failure. First line drug, we will use ACE inhibitors. We will add beta blocker. In moderate to severe cases, we will also add aldosterone antagonist. Look for hyperkalemia as a side effect, right? ACE inhibitors, if there is a side effects, we use ARB. If these are contraindicated, we use hydralazine plus isosorbide nitrate. All these have been shown to decrease mortality, so that is why they are used in CHF, to decrease the disease progression. Then in decompensated heart failure, yeah, here we can also add digoxin. If there is chronic, we have to control the ventricular rate chronically in presence of atrial fibrillation. So heart rate with AF, we can add digoxin also. Okay. Then decompensated heart, we have to give diuretics to relieve the congestive symptoms. Then we can give IV dopamine, dobutamine. Okay. Then IV nitrates. IV nitrates are given. I told you when, that if there is acute left heart failure with MI, that is IV nitrate. IV sodium nitroprusside, that is the one which is dilating both arterioles and vein. IV sodium nitroprusside is given in, again, severe decompensation, and other IV drugs. They like PDE3 inhibitors, levosimendan, they all are given in case of decompensation, only for short term. BNP analogs, they are given for refractory and advanced heart failure. Okay. So those were the various drugs which can be used for heart failure. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.